Check this out. Why empathy matters. Developing the business case. So we're talking about empathy on one hand and business on the other. All right. Got some folks in the audience that believe there is really an important conversation to be had. And isn't that what we are here for, to look at a holistic humanity approach to this important work? So with that being said, this topic that is under consideration here is very intriguing. It's one that studies have indicated that quality advanced care delivery is very important in supporting patient health. Some have cautioned about the costs involved, but other studies have indicated that there is actually a reduction in costs as advanced care is delivered. And I know some of my friends and colleagues out there will definitely say yay and amen to that point. So to pursue this topic, we're going to invite two experts to join us at the stage. Lauren Harden, a registered nurse who is Senior Director for Cross-Continuum Transformation at the National Center for Complex Social and Medical Care, and Ben Carter, the Chief Financial Officer at Trinity Health. Can we welcome them to the stage? Thank you.
Good morning. I'm really excited to talk with you today. I had a very interesting background that brought me to understand the importance of empathy and the business case and balance. So, we have some slides. It all started about 10 years ago. I was very happily the director of a very large palliative care program in a hospital in Michigan. And I worked on most of the complex cases. We had ICU, ED, inpatient, outpatient palliative care, and long-term care. And I got a call asking to get involved with a case that had nothing to do with palliative care. The person that called said, whatever that complex thing is you do with the complicated palliative care people, we want you to do it with this case. I knew I was in trouble. When people call in that kind of situation, you know it's got to be something really, really complicated that really smart people have not been able to solve. So I looked deeply into the record of the patient that was being referred. And what I found was heartbreaking. She had multiple providers from 3 different health systems. She had 4 different agencies visiting her in the home. She had multiple visits to the hospital. She was coming daily for treatment. And when I read her record, I found the heartbreaking situation that she was actually being treated for a condition that she had been diagnosed as not having. The fragmentation in the medical record had prevented that from being translated across settings. This whole myriad of care providers had started to fight with each other because there was so much fragmentation in the story. So I pulled everybody together in a shared conference, facilitated dialogue, facilitated a shared plan of care. The patient needed integrated behavioral health. She needed a different kind of treatment plan, and she needed the providers across settings to be talking with each other. We made that collaborative plan, transitioned her to the right integrated care, and it ended up saving $1.3 million in unreimbursed care. And that was an annual cost, and she'd been coming at that rate of cost for 5 years. So that was really exciting. So 10 years ago, before value-based payment. So the hospital said, whatever you just did, go do that some more. But do it without a budget or staff. So I had a really great window to experiment without being driven by payment or a grant or an external decision about how I did that. So I dived deeply into the high frequency, high cost, high needs population, did an intervention model, created that, intervened with about 250 people, and a year later went gladly to report to my executive team what had happened. The reduction in visits in that population was greater than 50%. Really, really strong outcomes. And I was really excited to share it because I'd seen transformative stories of quality of life improvement. The executives were very quiet when I made the presentation, and I didn't understand why. I thought they would be really excited and I would get a team of at least 10 staff and start a whole service. And I walked out of the room, and the CFO, who ended up being my best teacher ever, jokingly said to me, "Lauren, we're going to hold you accountable for a $2.6 million loss in our bottom line. Utilization equals revenue." I'm a clinician. I helped people. I wasn't thinking about this. But what his joke to me ended up being the best lesson I ever had to take forward. I was tapping into one of the biggest tug-of-wars that I think is underneath our challenges with moving this work forward in the business case. On one side, we have the polarity of margin. On the other side, we have the polarity of mission. If you read Barry Johnson's work, he speaks deeply about managing these really hard problems in healthcare that seem like they're completely opposite, either or. But really what is helpful to do is to learn how to bridge those polarities and work with both, because you need them both. That's how I became best friends with my CFO. And that's why I brought the Trinity CFO with me today to present together. So, empathy and margin and mission and bridging that. I started meeting regularly with the CFO. We started bridging culture. How did he see the world? How did I see the world? How could we create a collaborative vision to help vulnerable populations and move this work forward? What were the skills I needed to learn, and what were the ways that we could help each other translate mission and margin into one integrated story? I now use that around the country and partnering with all kinds of systems and helping them move this work forward. So we were building a new bridge. These were the key parts that we articulated as part of that bridge that are core principles I use in all the systems I work with. The first thing is starting with the why. What is our shared mission, our burning platform? Why are we doing what we're doing? Everybody inside, no matter what seat you're in the system, can get around that if you have the right dialogue. The second thing is taking a 360-degree view. It wasn't just about looking at what was the impact on the patients I was touching, but looking across the community to see what would be the benefit in a 360-degree view if somebody who had 100 ED visits in a year and 75 emergency EMS transports and was homeless and was also addicted. Who were all the people that would be touched by this situation getting better? So looking at the business case through that lens. After the 360-degree view, identifying partners inside your system, but also outside. The system's really our community. So who are those partners, and how can we share data to strengthen the story? Then looking at 4 quadrants of outcomes. The first one is cost. The second is utilization. You know those. The third is also always including quality. And the definition of quality is going to depend on your population and situation, but how can you integrate quality outcomes to round out the story? And then the fourth and most important quadrant, I think, is capturing the story. So having the patient, family caregiver voice, as well as the provider voice. Part of why we have so much burnout, I think, is providers are suffering at the point of care in this margin and mission squish. And the more that we integrate those voices in the story, the stronger business case we get. And then the fifth element is scaffolding implementation. So what Dan helped me to see is if I went out and helped everybody, which I couldn't do as one person, I could really upset the margin, really upset the business model. So I could intentionally design what I did in stages. So I built support for the business case, starting with the uninsured, all of them, then Medicaid, then Medicare, then private, but really building the business case collaboratively so it could scaffold and get all around support and keep the business model in balance. So a system that I work with on the national level that's doing this is actually, I'm sorry, it's in California. So I didn't know it was a California thing. I could have showed you another one, but Lake County is the poorest county in California with some of the most challenging health outcomes. Their why is that their community was devastated by addiction, lack of affordable housing, lack of providers, lack of transportation. So they came together across the community. This is the mayor, the chief of police, the chief of fire, spiritual care, social work, behavioral health, all the health systems. They created a collaborative called Project Restoration, and I've been working with them for the last 2 years. They share metrics, so they track how many reductions are there in jail days, how many reductions in EMS transports, in police calls. They collaboratively intervene with vulnerable population or vulnerable people in their community, and then work on process improvements based on what they learn. In their first year, they've seen a 50% reduction in utilization in the population, a 60% improvement in financial performance across the agencies, and they just received $1.3 million from a payer to build a collaborative community center. So a strong business case balancing margin and mission can really work. So what does that look like on the national level with a large health system? I'm going to turn it to my partner, Ben, to talk to that.
Thanks, Lauren. So I'm the empathetic business guy. It's important to have one of those in every organization. But, Trinity Health is, in fact, a large healthcare system that spans across the country. To give you a sense of Trinity, if you don't know us, we're an $18.3 billion revenue organization. We own and manage 94 hospitals, 19 PACE centers, that's the program for all-inclusive care for the elderly, 107 continuing care organizations, a home health agency that does over 2 million visits a year, so a large organization. But we also provide $1.1 billion of community benefit every year as well. So a large part of what we do is giving back, supporting all the communities that we're in, and you can see that we're in many communities. We're a faith-based organization, Catholic healthcare organization. We have a mission, and our mission is to serve together in the spirit of the gospel to provide compassionate and transforming healing presence in the communities that we serve. So compassion and transforming are a critical part of our mission, and our system board holds us accountable to that and holds the organization accountable to that through each of its regional boards as well. So we have a strategy to develop the triple aim for individuals, populations, and communities. And triple aim being better health, better care at lower costs. And it's important because you can see we have episodic care. That's where we came from. That's the fee-for-service world that you've been hearing about. Sometimes an impediment to doing the transformative work that you all have been talking about here today. But equal to that is population health. And really saying, we're not just in episodic care. We are moving to be transformational through managing populations and value-based relationships with the government, with private payers, and so forth, even with employers, to manage total costs of care, doing it the right way, not driven by a fee-for-service, kind of upside-down economic model of doing the right thing. And then community health and well-being, equal footing, serving those who are poor and other populations and impacting the social determinants of health. We intend to impact the social determinants of health. So we have 6 kind of focus areas that PEOPLE stands for. Patient-centered care, engaged colleagues, operational excellence, physicians and clinicians working together, leadership nationally. So we're not doing everything ourselves, but we're leading nationally, and effective stewardship. So this mission and margin clash that Lauren talks about, the polarity that she talks about, we manage that every day. And if you listen to our CEO, Rick Gilfillan, talk, he talks about the flywheel. And he's actually kind of created from, the good to great, the flywheel. He's created a flywheel that actually has moving parts to it that shows that if all of this works together, the episodic care, the population health, and the community health and well-being, it all works together, we grow as an organization, do better as an organization. In fact, that's happened. In the last 3 years, our operating margin has gone from 0.9 to 1.5, and you may have read just recently in Becker's and Modern Healthcare, released early this week, our operating margin was 2.2% in the year that just ended, fiscal year June of 18. And again, that's also including providing $1.1 billion in community benefit. So these things can work synergistically together. And our approach in people-centered care really kind of forces us to continue to kind of work the margin and mission and doing it together, not against, but together. When we focus on the right-hand side of people-centered care, we talk about the social determinants of health. We focus on that in all of our communities. We're in Detroit. We're in Atlanta. We're in Philadelphia. We're in Camden. We're in Trenton, New Jersey. We're in some really tough areas, and we see the impact of social determinants of health and how education, employment, social and community contexts, healthcare, and neighborhood and environment all impact those and how they align with wellness. So our focus is really then blowing that up and saying clinical delivery of services, community engagement, and community transformation, and how do we impact those? And again, you see things here that one might think of, and some CFOs might think of as destructive to the business model. But we don't see it that way. It may be disruptive, but it's not destructive. And it's how it works together to balance the margin and mission. And Lauren talked a bit about that, but you know, when you reduce readmissions, reduce ER visits, and reduce things on a fee-for-service side, you'd think, gee, that could really destroy your margin. But if you're not getting paid for it, it's actually improving your margin. And that's the critical piece of this. We also work with those in our communities because we know we can't do it all. In fact, $75 million of our investment portfolio is committed to social responsible investing. So we're doing low interest rate loans to help develop communities, housing and other initiatives in communities, and also actually putting money to work through some private equity funds that are backing socially based for-profit organizations impacting social determinants of health in the communities that we're in as well. However, at the end of the day, yes, a business plan has to be created. And many think of a business plan as like the death knell to an idea, right? It's like, oh my gosh, they want me to develop a business plan. That means it's a kill point. It is not a kill point. You really need, this is where collaboration with your finance team is really critical, because what a business plan does is it really takes those thoughts and those ideas, like Lauren talked about, and it sets it in terms of key expectations. So you have a summary, you have your idea, you have the markets you're impacting, you have the operational plan, and you have the financial expectations that come from that. And it will actually help you crystallize with your executives, your boards, your communities, what it is that you're doing and why there's a benefit to it ultimately, including a social benefit, a mission benefit, and a financial benefit. So in Lauren's case, and by the way, this was in Michigan, not California, Michigan. Woo! So when she worked with Dan, the VP of Finance there, and you know, an empathetic finance. I know it seems like you know, an oxymoron, right? You can't have that.
And they're fun.
What's that?
I said, and you're fun.
That's right, and we're fun too. Imagine that. So they put together a business plan and actually had proposed an investment of $3 million, but was going to have a 28% return, targeting 900 people, and so that allowed for the commitment of resources, because Lauren started with no resources. That allowed them for the commitment of resources, and the actual financial performance is the investment was less. The return was over 20% over 2 years, so going to exceed the performance expected, and impacted 1,000 patients in the population. So, had a pretty significant impact. But the business plan really allowed for that and got the, got the support of all executives, including, by the way, at the parent level, the Trinity Health executives as well. And I can tell you that our CEO was your biggest fan. He was so, Lauren really kind of set the example of what, he wanted early on when we were moving into this people-centered strategy and trying to get the traction away from a fee-for-service dominated environment into something different that was going to be, in fact, transformative. And she set the stage for that. But at the end of the day, it's how it impacts individuals. And so this is a recent story that we're sharing. In fact, we're sharing it with the rating agencies and our bond investors in meetings coming up in the next couple of days. But Benita, who is from our Holy Cross Hospital down in Florida, was one of those frequent flyers, 50-plus visits to the emergency room, 20-some, hospitalizations every year, so many different comorbidities, being, that she had. And by using our population health nurse navigator and community care coordinator, we're able to really address her social determinants of health, establishing a plan with primary care, pulmonologists, nutritionists, and cardiopulmonary rehab program, whereby at the end of the day, she's now on a care plan. She goes to her doctor and doesn't go to the emergency room and has required no further hospitalizations. And this is why we do what we do, and this is where empathy comes into play as it impacts people down at the individual level. And again, how margin and mission actually work together to develop better communities and strong financial performance as well.
So empathy and integrating that in the business case starts with understanding that shared why, but it's also extending our interprofessional practice to include the CFO and partnering with finance, and then also partnering broader across the community and looking at who are our other partners in this work. So we were going to do an exercise, but I bet you that you do not want to be late for the break, and we have 4 minutes. So we'd like to open it up to just see if there's any questions or comments you'd like to make about your challenges or successes with integrating margin and mission in the business case. Oh, Pat, come on up.
Hey.
This is extremely fun for me. I'm really enjoying what you have to say. It also gives me a chance to say that I'm late from Minnesota, so not
Hey.
California. Yes. The story that you tell about being able to bring together margin and mission and doing so in a way that helps an organization to understand how it can reframe the way it articulates values is critically important. I loved the story you told Lauren about Lake County, because to me that was a story that kind of showed the benefits of understanding the wrong pocket problem, where a community, and I would argue perhaps a community that was struggling with its own economic vitality beyond the healthcare challenges and social challenges that they faced, was able to realize a benefit that stabilized some of the infrastructure that they depend on to be economically vital. Can you speak a little bit about how your work and Trinity's work helps to increase or improve the economic vitality of the communities that you serve, and how that enters into your conversations?
Definitely. So when I was working with Trinity, I got to see that on a local level with the model. So the model was focused on helping patients, but there were process improvements built into it and community collaborations. That's when I started out alone, I couldn't take on all these complex needs alone. So it was really critical to build collaboration to improve delivery. Now I work for the National Center for Complex Health and Social Needs and help all kinds of people build out these kind of interventions, whether it's payers or government or communities. What's happened in Lake County is they realize the riches they have in each other. So within 9 months, they collaborated and opened a 10-bed transitional housing unit. They don't have any affordable housing there. They've had multiple fires. As a community, they came together. There's people volunteering to bring in food. Somebody offered up some land. Somebody else offered this resource. There were resources already there. They just needed an avenue of collaboration and a burning why about how to come together. Now, in that transitional housing center, the way they built the principles is the people who live there also run the community. So the people who are formerly living under a bush downtown and having multiple public disturbances in this model are integrated as really, really important parts of the community too. So they're helping, they're volunteering, they're cooking food, they're peer support for the new people coming on, and then they're on the Project Restoration Collaborative. That kind of generative resource exists in all of our systems. The providers at the point of care want things to be different. They're a big resource we can tap into. And within our communities, it's just really thinking a little bit differently and understanding that empathetic view.
Wonderful, wonderful. Ben, there's a term that I often see used for business cases. Actually, two terms. One is hard benefits, one is soft benefits. And I really don't like using that terminology. I think of financial benefits and clinical benefits and human-centered benefits and those kinds of things. I'm curious about how you, as the Chief Financial Officer, engage in supporting a conversation that is broad enough to be able to incorporate all of those different types of return when an organization is making investments in new programs and new approaches.
Yeah, you know, we really, and I personally take a very balanced approach. So because community benefit is, you know, embedded in our mission itself, it's actually embedded in the way the board evaluates us as executive managers as well. So, so when we, you know, some might think that the soft benefits are, well, what impact does it have on the community? What impact, you know, does it have on the social determinants of health versus the, you know, dollars and cents ROI type of return? But I'm held accountable for all of that, and so so I have to. I know it sounds mundane and trite, but you know I've got to take that balanced scorecard view, if you will, and understand that, you know, as we're evaluating these programs, that we can clearly kind of draw the lines to kind of all the key things that we're looking to impact. I mean, because we want to impact the needle on social determinants of health in each community, obesity, smoking cessation, food and nutrition, housing, and so forth. And so being really clear about how it's impacting all of those. So, so it's just taking a well-balanced approach on that.
That's terrific. I'm going to ask you both one final question, and I'm going to tie this question back to the previous panel conversation. In the Q&A at the end of that panel discussion, there was, I think, an important question raised, and that is, in the context of a value-based model for paying for health and wellness in communities, for paying for care, how do you see community assets, community entities, NGOs, and others participating in that value-based system so that they are both sustainable and they can contribute in a meaningful way to the overall financial performance of a model like that?
Yeah, I guess I'll start. I mean, first of all, just, you know, as I mentioned, we have the kind of those three areas: population health. That's kind of where we have what we call the value-based, and our goal is to move as much into value-based delivery of care as we can, so that we're just incentivized to do the right thing for people, and so we recognize that part of that involves, again, all the community in each community, the community partnerships that we have, and in many of our communities, I mean, we actually have created centers where not just healthcare is delivered, but but connection to housing and food, education, and is there as well, daycare and so on, so that so people's health and well-being can ultimately be augmented. So we view that as all, again, working together. But really, our goal is to keep moving out of fee-for-service and into value-based, and to do the right thing to deliver the triple aim: better health, better care, lower cost, and healthy communities.
That's great.
And I would say one of the biggest lessons I had in this, when I first had the first year of intervening with high-frequency patients, I looked at data, I got to know people's stories, and all of a sudden, wow, there's a homelessness issue underneath some of this. That's so radical. I need to work on housing. And that was very arrogant on my part. And I quickly learned that there were all kinds of people in the community who were really good at housing, and all kinds of agencies already working on this. And it wasn't helpful for me to come up with a brand new idea about how it should be done. The most helpful thing was to collaborate and share some of the data access I had, and some of the financial resources, and some of the coordinating services to pull things together and bring the experts together. Now with the National Center, there's at least 4 communities I'm working with. When we go into these co-design partnerships, we teach people about looking at an ecosystem of complex care. It's not just about the emergency room or just about 30-day readmissions. It's cross-continuum ecosystem. We help them do asset mapping to look at what are the resources in the community for complex patients, identify key partners, convene a collaborative, and work together. And that kind of work is getting really exciting attention and interest from funders, everywhere from payers to private foundations. I was late today because I was on a call with some folks related to that. Those resources are there to invest on a broader level, but the resources have to be shared with these very important community agencies who individually, sometimes in silos and sometimes in competition with each other, have been trying to hold together the safety net. And when we pull together and collaborate, there's really, really amazing outcomes that can happen.
It's a wonderful story of making evident and making clear how that value-based model creates dependencies that we didn't realize existed before. I love what you said too about recognizing that there are others who have been working on these problems and have ready-made solutions. One of the reasons why I feel that that's so important is because when health care as a system identifies a problem and goes after it, one of the things they do better than anything else is making a solution that's fabulously expensive.
Yes.
And
we're really good at that.
we are. And being able to find ways to both identify the problem solvers that haven't been a part of that conversation in a way that is connected to the model of payment, and taking advantage of the fact that they can do that work in a much more cost-efficient way and deserve to participate in the flow of resources that society entrusts to the system is, I think, a really important insight, and will be driven by the kinds of business model complexity, the business model approaches that you're talking about here. So thank you very much. Please give a warm round of applause. Ben, Lauren, thank you very much.
So a bit of a sponsor and supporting organizational commercial, if you will, and no less extremely important. It's important to note our supporting organizations have selected the CTAC Summit as the platform for making commitments to strategies that support those who suffer from advanced illness and their caretakers. And it's a welcome addition to our program. So we thank all of them for their support and welcome the news of the plans going forward. I'd like to welcome to the stage Joan Harvey. Joan is Senior Vice President of Consumer Engagement with Cigna. And Joan and her organization, through the Wilson Foundation Commitment, would like to speak to us about that. Cigna. Correction, Cigna. Thank you so very much, Joan Harvey. Good to see you. Good to see you as well.
I think I need the podium to mount my.
Yes.
Well, good morning, everybody. It's a pleasure to be here. I've had the pleasure of working with CTAC for a number of years and was asked to talk about what is sort of the commitment that we're continuing on our front to move this cause forward. And so for folks who know Cigna, we primarily insure large employer groups. So our challenge in this space is unique, right? Because we're going after sort of not maybe the Medicare and Medicaid markets. We have some of that book of business, but we are primarily an employer-sponsored health plan. And so in looking at that, we decided, well, the way that we can really support our employers in the cause of moving this forward is to focus on the caregivers, the family caregivers, the people that are employed and working and living dual lives, you know, coming home to your second shift, as we heard earlier, to care for your family members. There's a lot of unmet need and challenge, and now a very strong recognition from employers that this is a place that they really do need to focus, and how can we help do that? So ours has really been sort of a two-phase front. The first front is our Cigna Foundation has partnered with CTAC on a multi-pronged grant. The first part of that grant was a study we did last year around digital ethnographic research to understand the true need of caregivers, the pressures they're receiving. And we presented these findings, for folks who were here last year, we presented these findings at CTAC last year. I think we were quite opposite of what we thought we were going to see. So now we are involved in the second part of that grant, which is to say, how do you take that information and actually do something meaningful in our communities to support those issues and insights that we found in the grant? And so we have been working on that, and we have finally come to what that second part is going to look like. And we're going to really focus on what we're calling overcoming the digital and community divide to empower caregivers with resources. And so we're going to do that in two ways. The first way is that we're going to be partnering with faith-based organizations that work with CTAC, with Rabbi Address and Reverend Rays. Hi, see you out there. And we're going to be using sort of their vetted quality caregiver resources within their communities, and in turn providing access to those through caregivers in their congregations, so they can really get at that community support sort of through that sort of front, and very excited about that. The second way is that we're going to go more of a digital intervention, and we're going to be partnering with Tim and Ramey, who authored Driving Miss Norma. You saw them last year at CTAC as well. They actually have a Facebook following of over 500,000 people in their community, and so how do we really, use that community and support that community with caregiver resources in a very different way than obviously we would do through a faith-based intervention. So my first commitment is that we are going to execute that, and we will be back here next year to tell you the findings of our results on sort of our foundation front. The second area that we're looking at is really partnering with our business associates within Cigna. So our employers and the people that we insure, we do a lot of innovation integration partnerships with them. And there's huge interest in caregiving. So we are actually we've launched one, and we're launching 3 more this fall, pilots around how to work with our employers on caregiver interventions. And how do we look at the kinds of services that we already have that are very underutilized and totally restructure how we deliver them into the marketplace. So many of our employers have medical benefits, they have behavioral benefits, they have EAP services, disability services, and they work in these silos. And what we learned through the caregiving piece is that it's very difficult and complicated for a caregiver to access those benefits. Most of them don't even know that they have many of these benefits. There's so many things under EAP, for example, legal services, financial services, dog walking, caregiving, things that people could use to really take that stress and burden off. So we are launching these 4 pilots with employers. We are also including employers who have integrated delivery systems. We employ we insure their employers, but we also are going to work on how do we help their integrated delivery models from sort of ACO levels down into the hospital. So my second commitment is that we will bring back the findings of those pilots, what worked, what didn't work, and what we're going to look to scale for what worked at next year's CTAC session. So thank you very much, and look forward to our continued work with CTAC. Appreciate it.
Thank you, Joan. Cigna is taking action and moving forward in some exciting collaborations and innovations, and we are thrilled about that. All right, folks, how you doing? Ready for a break? I can imagine so. You have been amazingly patient and interactive, So before we actually move on to concluding the morning plenary session, we really want to thank you for your engagement and just your interactive nature in this incredible second day of the CTAC Summit. So now it's time for a well-deserved break, chance to explore the offerings and sponsors, exhibitors. Many of us have to make important phone calls and emails and so forth. But let me just say there are three important things that we want to stress before we leave this session. First, the breakout topics are listed in your program book, and you will see signs posted outside each of the breakout rooms to guide you. Please note that all the breakout sessions are on this floor. And while we know that there are several breakout topics that will be tremendously compelling, we want to offer what we would call a bit of an inside baseball pitch, if you will. And that's for the lab session that's focused on the 2018 CTAC Advanced Care Transformation Index. So we'll get a sense of this ambitious project tomorrow morning in the plenary session, but this afternoon, the leaders of this effort are enlisting your insights, your wisdom, and recommendations to assure that the resulting index reflects your expertise and responds to your organization's challenges. And the plan for the 2018 index includes performance data for all 50 states and the District of Columbia, which will include a best practices library and linkages to experts who can support your performance improvement efforts. Third point, we will meet again in this room for lunch and a video. So you'll pick up your lunch in the foyer area, bring it here to view InGame. How many of you have heard about InGame? All right, well, you have an incredible opportunity. We all have a great opportunity to view this award-winning documentary that is currently playing on Netflix. The executive producer of InGame, Dr. Shoshana Ungerleider, will be on stage after the screening, along with Dr. B.J. Miller, a palliative care physician at UCSF and infamous for his talk and the TED Talks. We'll also have, as the moderator of that viewing, Peggy McGuire, the president of Cambia Health Foundation. So that being said, I'd like to thank all of you for your attentiveness. Thank you for your engagement. Please enjoy the refreshment break, the breakout sessions, and we'll see you again this afternoon. Thank you all so very much.